welcome from Adelaide, Australia, and thank you to the ESSO for selecting our abstract for the presentation. Our presentation is called Malignant Features in Pre-Treatment Lateral Pelvic Lymph Nodes in Low Rectal Cancer Predict Distant Metastases and Survival, but not local recurrence. We have no conflicts of interest. Low rectal cancer metastatic pattern to the regional lymph nodes basically happens in two ways. The most common one is via the inferior mesenteric artery into the mesorectum, but also some patients have lateral lymph node metastases, mainly in the internal iliac or the obturator areas. Up to 20% of these patients with low rectal cancer have positive lateral lymph nodes in these lateral lymph node compartments. And these lateral lymph nodes, if they are metastatic, comprise a diagnostic and treatment challenge. The aim of our study was to look mainly at the malignant features into these lymph nodes, because enlarged lateral lymph nodes have been shown in previous research that when they are treated according to the Western standard of neoadjuvant chemoradiotherapy followed by TME resection, can cause local recurrences. But not much is known when these malignant features are present in the lateral lymph nodes. We therefore collected patients from 5 hospitals, tertiary referral centers in the Netherlands and Australia, and we included patients who were diagnosed with low rectal cancer with or without abnormal lateral lymph nodes on pre-treatment MRI, and all patients underwent neoadjuvant therapy followed by TME resection. Lateral lymph nodes were considered enlarged when they had a short axis of larger than 5 millimeters on pre-treatment MRI and when they were located in one of the lateral lymph node compartments. Malignant features in the lateral lymph nodes were seen on the pre-treatment MRI as internal heterogeneity or border irregularity. We found 213 patients that we could include. 2/3 of the patients were male. The median age was 64 years old, and 98 of the patients had normal lateral lymph nodes, so 0 to 4 millimeters or no malignant features. And 115 patients had positive lateral lymph nodes on a pre-treatment MRI, so larger than 5 millimeters or malignant features. The short axis was 7 millimeters of the positive lateral lymph nodes, and 60 patients had lateral lymph nodes with malignant features. The size predicted local recurrences, as we did predict beforehand, and the lateral lymph node size also did not predict distant metastatic rate or overall survival. They were similar according to the size ranges. However, the local recurrences in patients with lateral lymph nodes with malignant features were similar. So the local recurrences were similar with or without malignant features. And the distant metastatic free survival and the overall survival were worse for patients with malignant features in the lateral lymph nodes. So is there a good, the bad, and the ugly? Good, the normal nodes, the bad, enlarged or malignant nodes, and the ugly, enlarged and malignant features in the nodes, causing both local and distant failure rates. Of course, this is a retrospective multi-center analysis. No restaging was performed, and no response to the lateral lymph nodes was captured because we didn't perform any lateral lymph node dissections. Future studies, as these two, will show this in the future. So in conclusion, unlike size criteria, malignant features present in the lateral lymph nodes on pre-treatment MRI may predict worse disease-free, distant metastatic-free survival and overall survival, but not local recurrences. I would like to thank our international collaboration with long-standing international collaboration with Netherlands and Australia. And I hope to see you all sometime again in Adelaide. And good morning from Adelaide. Thank you very much.